Well, good evening, afternoon, or morning to all participants joining us in Singapore and from around the world. My name is John Lim, and I'm Executive Director of the Center of Regulatory Excellence, or CORE, at the Duke-NUS Medical School in Singapore, and also Policy Lead of the SingHealth Duke-NUS Global Health Institute, or SDGHI. Welcome to the third session in CORE's 2020 series of topical webinars related to the evolving COVID-19 pandemic. Today's webinar focuses on the impact of COVID-19 on patient engagement in East Asia. In recent years, an important global conversation has been happening among health system stakeholders on the value of engaging patients and involving them in medical research, therapeutics development, regulatory approval, healthcare provision, and setting health policies. In East Asia, unlike in other settings, such as the US and Europe, patient group interaction with governments, regulators, and companies is still relatively nascent. But stakeholders in our healthcare ecosystems are increasingly recognizing the importance of expanding the role, the visibility, and the voice of patients and patient groups to improve healthcare delivery and policies. In October 2019, CORE partnered with Faster Cures, a center of the Milken Institute, to organize an inaugural regional roundtable in Singapore. This brought together 56 participants and observers from 13 countries, representing patient groups, ministries of health, national regulatory authorities, clinicians, healthcare administrators, academics, and industry. Since then, CORE has been working with our partners participating in this webinar to provide a neutral regional multi-stakeholder platform for supporting and accelerating patient engagement in the Asia-Pacific. Of course, when we convened the roundtable last year, we had no inkling of what the world would be like in mid-2020. A lot has already been and continues to be discussed on the devastating impact and burden of COVID-19 on health systems and economies, lives and livelihoods, physical health and mental health. But a major aspect that has been largely unaddressed so far is what has been the impact of the pandemic on patient engagement and the work of patient groups that have been painstakingly built up over the past years. It is therefore timely that today we can hear from experts from several Southeast Asian countries on the impact of the COVID-19 pandemic on patient engagement in their communities. This is an issue of interest and concern, not only for CORE, but also the SingHealth Duke-NUS Global Health Institute that focuses on health issues in Southeast Asia. We are very privileged today to welcome our experts and panelists. And we have Mr. Rajakanth R, or Raj as we call him, who's visiting expert with CORE and Executive Director for Rainbow Across Borders and Principal Consultant of Manifest. Mr. Nicholas Brook, Executive Director of Patient-Focused Medicines Development, or PFMD, and the Synergist. We're also delighted to be joined by 5 patient leaders from the region. Mr. Elil Mathian, President of the Ostomy Association of Singapore, Mr. Kenneth Ma, co-founder and vice president of the Rare Disorder Society Singapore, Ms. Fatima Lorenzo, president of the Philippine Alliance of Patient Organizations, or PAPO, Mr. Ekawat Suwantaroj, vice president of the Thai Hemophilia Patient Club, and Ms. Penny Utami, chairman of the Indonesia Rare Disease Foundation. We're also joined by our colleague, Ms. Kristen Schneeman, who's director for programs at Faster Cures. Now, in the interest of time and to allow more engagement among the panelists, we will not be taking live questions and answers today. However, for those of you who submitted questions when you registered, we will aim to address those points and questions during the course of this webinar. Without further ado, I would now like to hand the time over to Raj, who will first share his thoughts on how COVID-19 has changed patient engagement in the region. And after that, he will facilitate a panel discussion with our patient leaders, together with Nicholas Brook as resource expert for the session. So over to you, Raj.
Hi, thank you, John. Let me start by saying thank you very much for joining us this evening. My name is Raj. I think John has already gone through the introductions. So I think today what we're going to try and do is to set the stage for patient engagement, and also the next part will be what has changed for patient engagement during this season of COVID-19. First slide, please. So what we're going to do is try and look at the framework of patient engagement. And this framework here is a model that we can use, a very strategic model that we would like to have in most countries. And it's covering 3 different tiers. The direct care, that would be, and the hospital structure and governance, policy shaping as well. Who are we looking at? So we're looking at 3 different entities. We're looking at the patient, who will bring together the beliefs, social norms, culture, health literacy, and education. We are talking about the hospital, the treating facility. We are talking about the ministry. So when we look at the direct care, we're looking at what sort of engagement would the patient have? 1, I think it starts off with a very simple diagnosis information that's being shared with the patient from the primary clinician. Next, the patient's preference in treatment plans that will be discussed with the physician. And the third point will be tailor-made treatment based on the patient's preference, medical evidence, and clinical judgment. So that is the very first basic encounter and a very successful patient engagement model to start with. The next would be at the treating facility, the hospital structure and the governance. Hospitals should, 1, survey the patients on their experience in the facility, and also next move on to actually try and engage patients as advisors or care experts at the hospital level. That would actually finally move on to a partnership model of the hospital safety and quality improvement should have a couple of patients being part of the panel or being part of the board or the quality assessment team. The third that we'll talk about would be trying to shape policy. How do we start? Most of the time, we would need to actually figure out what the culture of the country is like, what the political situation is like. But I think the best case scenario would be to, 1, the ministry to conduct focus group discussions with patients on healthcare issues. So I think this starts the ball rolling for a very friendly relationship, a collaborative moment, as well as partnership encounters. The next would be patient recommendations and research priorities used in funding decisions. So that would then focus immediately on patient centricity. Patients have a say in the healthcare decision-making process. Patients will have their voice recorded, and I think the decisions that will be taken in the next and final step will then lead to a good partnership model that is a win-win situation for both the ministry as well as the patients. The third level would be patients represented at the ministry panel on an ongoing basis on how healthcare programs can be resourced. I think that would be the ultimate solution to most countries. I think there are some countries within the region that have got successful models. In Thailand, they've got the Healthy Forum. I think in Singapore, they'll start to move towards that as well. So I think, this is something that we can strive to achieve in the next couple of years. Next slide, please. So with patient engagement, this is just the framework. We're not going into COVID as yet. We currently have issues that are left unresolved in this region. 1, culture plays a very important point in the challenges in trying to engage patient into the whole system. There seem to be no predetermined guidelines at this point of time on how to engage the patient, how to implement the engagement as well. The lack of evidence adds to the whole issue of, the whole, what do we do? How do we involve the patient insights? How do we then document what needs to be done? Where is the evidence? So that makes communication very weak. There are patient factors as well. So that's something that we need to look at as well, and the health literacy, poverty, as well as the familiarity with the technology settings. Patient perception is another huge area that we'll need to look at, because patients often have predetermined notions that their role and status are subordinate to medical professionals. That seems to be very prevalent in this part of the region, where I think most patients look up to the treaters as gods, or the ones with the perfect answer. So I think what we need to get into is a model which is collaborative, a little bit more of a partnership. And the last would be workforce reluctance. Are our healthcare professionals and allied healthcare professionals ready to accept patient into the whole working model? So that's another question that we will need to take a look at. Next slide, please. So with the current situation of COVID, we polled some of our colleagues, and we're going to look at 6 countries here. I know we've got representatives from Singapore, we've got representatives from Indonesia, Philippines, Thailand as well. But we're going to cover 6 countries so that we have a better perspective of the region. At this point of time, let's start from the top, which is Vietnam. During COVID, I think some of the challenges that they faced were disrupted medical support, information and access. Some hospitals closed down, no hospital visits, loss of income caused a lot of medical situations within the population as well. Now we move to Thailand. The patient advocate group started to play an increased role to engage patients. That's a positive. They became secondary care providers. They also helped to digitize patient meetings to keep in contact with them. That was important to actually make sure that the patients were doing well emotionally. But then they faced another problem of having disrupted medical support and access as well. We move over to Philippines. I think some of the issues that our colleagues have mentioned was there was no transportation, access to medication, food security, and loss of income. Patient advocacy groups provided for practical support for transportation and food during that season. That's a positive. Digital consultation was also put in place so that they could keep in contact to monitor the mental well-being of most of the patients and the caregivers too. Moving to Malaysia, they faced about the same problems of disrupted medical support and access. They put in place, some groups have put into place digital consultation. Patient advocacy groups were not equipped enough to actually support the need for some of these patient needs. No transportation was another issue to actually get patients to and from hospitals. Indonesia, there were some positives to start with. A specialty disease program was kickstarted just before COVID to actually help some of the patients. Patient advocacy groups were providing financial support to patients. Medicine imports were fast-tracked. That was another positive. Disrupted medical support and access, the same as most countries. And digital consultation became a part of life for most of the Indonesian population. Now, for Singapore, we actually saw, with the government's intervention, lots of digital outreach within the patient groups and charities. Online therapies took place, from art to occupational therapy. Government funding for digitization of patient associations also took place. But then and again, we faced the challenge of disrupted medical support and access to most of our patients, also to their caregivers. The next slide. So what is happening in the Asian context, and how do we get the patient engaged? Who are they, and how do we place the patient into the whole system? So most of the time when we look at this is the iceberg. In Asia, the cultural dominance is very, very strong. The strategy and the tactics are usually the tip of the iceberg. Culture, which is very deeply hidden and exerts a very powerful influence over the outcomes. And that really helps sustain the transformation, in the move forward. So what we're going to try and now strategize is who owns it and how do we move forward on it. So when we look at it, the tactics are usually suggested by the experts who can work the solutions. They may not be from the country, they may be from the outside, they may be investors. And we have the strategy that are usually the investors, and they are put together by achievers. Usually most of them are industry partners. But what's most important is the catalyst, because they focus on the culture and they create the vision and a breakthrough the culture. So who do we then term as the catalyst? The catalysts are my colleagues that you will hear soon from Singapore, Indonesia, Thailand, and Philippines. These are the people that we will need to get involved into the system, into the healthcare decision-making process, to hear their views and to use their views as experts to take things forward. So in a nutshell, can we have the next slide, please? Just like to actually keep this short in the interest of time. So one, I think some of the things that we've learned from the last 3 months of COVID is we seem to lack an evidence-based approach. We also lack patient insights and capability on trying to engage the patient a little bit further. What is clearly evident is most of our plans and frameworks aren't patient-centric. And what we need to move towards in this situation of COVID is to try and decentralize patient support programs, give more autonomy, give more empowerment to patient support groups to do it. We need to actually train the patient and the PAG leaders for readiness of digitization. We will also need to come out with documents of patient preparedness that can be disease specific to help the patient, the caregiver, and the community cope with specific diseases and the outcomes over a period of time. Thank you. I will now hand over to the panel together with Nicholas, and we'll have a discussion together with Elil, Kenneth, Fatima, Ekawat, and Penny. Thank you. Should we start by now visiting Singapore, since this is beaming live from Singapore at this point of time, and we will have Kenneth to start the ball rolling, and Kenneth is going to try and answer some of the questions by the attendees as well. So Kenneth's going to look at, he's going to share with us his experience with Rare Disorder Society of Singapore, as well as promising scalable avenues for patient engagement. Right, Kenneth? So maybe
Yes.
For you to start.
Oh, okay. I think more charities are moving into digitalization of their patient engagement during this pandemic. Okay, let me use RDSS as an example to start with. Okay, before COVID-19, we have always been in touch with our beneficiaries through the use of a digital platform such as WhatsApp chat group, private group in Facebook, and also email, like sending out mailers, all this. So we are constantly conducting survey and gathering feedback from our beneficiaries and their families via all these communication channels. Okay, we do host social events, like physical events, gathering, party, all this for our beneficiaries, and usually the turnout is actually quite good. As many as up to 60 families attend our year-end party last year. Okay, so unfortunately during COVID, we are unable to do the physical events. So during COVID-19 pandemic, especially during the circuit breaker period, we continue to adopt the digital platform to stay engaged with our beneficiaries, and we realize it's very effective way of staying in touch with them. So one good example is that through our chat group, we realized that many families are facing some difficulties in getting masks for their children. Yeah. So what we do is that RDSS gotten a donation for the children mask. So upon receiving, we actually pack it and mail out to the families that put up their request to us. Yeah. So due to social distancing and circuit breakers, actually our physical activities, events, and also home-based these therapies were actually either cancelled or been postponed. Yeah. So we actually through our internal discussions, yeah, so we actually adopted or start using some form of video conferencing to stay engaged with our beneficiaries. So we actually make use of apps like Zoom, Google Meet, all this to stay in touch with them. Yeah, and then it seems like virtual meetup is the in thing. Yeah, so we also realized that even among the families, they were actually socializing among themselves using all these apps. Yeah, so on top of this, we also actually came up with this Facebook Live to stay in touch with our families, and then to interview them to find out how are they coping during this pandemic. Yeah, and then also service such as this art therapies we was also conducted via online. So we have a few sessions of art therapies through online via this Zoom. Okay, then I would say actually this pandemic opened up an opportunity for us to learn and develop new communication skills, and also by using digital solutions to maintain our communication with our beneficiaries. Yeah, so even our government are actually encouraging us to do so by expanding their grants to, encourage us to adopt the, more digital solution in areas such as uh, this volunteer management, donor management, and even remote working. Yeah, so I think it's something that I think we will carry on, even after the pandemic, because it's really a very effective way to keep in touch and continue with our patient engagement. Thank you.
Thank you, Kenneth. Maybe you want to share with us a little bit more about Rare Disorders Society of Singapore. I think that's what people might be thinking, the who are the beneficiaries that you serve, the kind of work that you do. Yeah.
Okay, sure. So I'm also the founder of Rare Disorder Society. It was established in 2011. At that time, actually, my daughter was diagnosed with a rare condition called Pompe disease. So I realized that the kind of support and awareness on rare disorders or rare diseases is close to non-existing. Yeah, so I decided that someone has to do something. So I, together with my wife, we founded these organizations. So basically, as the name says, so rare disorder. So our beneficiaries are mainly, or should I say, all of them are been diagnosed with some form of rare conditions. And we do have also another group that is so-called undiagnosed. That means their condition is unknown. So we also accept them as our beneficiaries. So basically, we are an organization that focus a lot on patient support and their family support. So our so-called service and programs are all actually been introduced to support them, and we took a very patient-centric approach. That is why just now I mentioned about getting feedback, doing survey. So this is how we find out what they actually need. So we want to roll out programs or services that cater for their needs. Yeah. So this is what we are doing right now over at our RDSS. So yeah. So in fact, I would say it's quite worrying for me to see that over the years the numbers has actually increased. Yeah, maybe because of the awareness, and more people are getting to know about rare diseases, and then also many families are willing to step up. So I see an increase in the numbers of people coming to us seeking for support. So it's not just financial support. In fact, I would say a big group usually here for the kind of caregiver support, emotional support that is required. Yeah.
Thank you, Kenneth.
Thank you.
We'll move on to Fatima Lorenzo from Philippines. And I think she will be trying to address how can industry work to engage patients, as well as how are patients affected financially. Before we come to Nicholas, who will then try and provide for some solutions or even share some of his thoughts on Kenneth's perspective and Fatima's perspective. So yeah, Fatima, over to you.
Hello, good evening from the Philippines. The Philippine Alliance of Patient Organizations is composed of 32 disease-specific patient groups, and we represent about 1 million Filipino patients. And our mission is to be the Filipino patient's voice. I'll focus first on the current situation of COVID in the Philippines. recently, just a few days ago, WHO reported that unfortunately the Philippines is the highest confirmed cases in Western Pacific and in the 22 regions. And the projection is that by the end of July 31, by our University of the Philippines experts, we will reach about 60,000 confirmed COVID cases. So clearly there is a crisis and a pandemic happening in the Philippines. So how are we as patient groups trying to address this or help the government address this? So one is when there was a call for ethics guidelines for how to treat COVID patients in the hospital, PAPO was there to help the experts from PGH and Department of Health to write what is needed for patients to be able to get the proper treatment. And one particular thing that we advocated for was the connection of the patient when he is being treated in the hospital. He has to continue to be connected to his family. And that is what we put in the ethics guidelines. And so now hospitals have a device that either their nurses will have cell phones or iPads and all that, so that the patient, however, can connect to the family, because it's very important for that connection. Another thing that PAPO did was during the joint congressional hearing on the universal health care, the implementation of universal health care, there was a suggestion from PhilHealth, our Philippine Health Insurance, to delay the implementation of universal health care. And we said, we verbalized our position that it should not be delayed. Funds should go into the universal health care, and it should be implemented right away, because if there was anything that COVID showed us, it was really the value of having universal healthcare and that health service delivery network in the community level, in the LGU level, because the government is practically leaving the solutions of COVID to the local chief executives. So it has to be done. And thirdly, we also wrote a manifesto because the non-COVID patients were really left out in the cold. There was no transportation for non-COVID patients to go to their treatment centers. There was no access to medicines because the community, the treatment center in their community did not carry the medicines that the cancer patient had or the dialysis patient had. So what we did is we wrote a manifesto and submitted it to the task force. We were one of those who were signatories that they should have policies also for non-COVID patients. So that is on the national level. But on the individual patient group levels, we gave funds for our patients because aside from health, they have issues of no work, no pay. So they're going hungry. So what we did was, fortunately, that in digital, we went from online banking. So we were able to download money for the patients. And another one was we really coordinated with the LGU. So patient navigation is very important. So now more than ever again, patient navigation. We guided the patients on how to get transportation. Talk to your LGU. And then there were some patient volunteers who provided private vehicles so that they can bring the patients from their homes to the hospitals. So that's the situation here in the Philippines. So it's patients helping patients. And I'd like also to emphasize the role of private partnerships. The corporations really help donating PPEs and donating meals for our frontliners, for our patients, because clearly during the lockdown, our patients could not go out and buy anything, any food, because all the restaurants, all the canteens were closed. So it's really we call it in the Philippines bayanihan, helping each other to get through this pandemic. So, Raj, you're asking me about how industry can
work together to engage patients.
Yes. So
to encourage participation in clinical trials. Yeah.
yes. So with regard to clinical trials, actually, I have 3 suggestions for the industry so that you will be able to move forward clinical trials. One is first an orientation for patient groups or for the patient leaders, because we need to understand what clinical trials, what it entails, especially with regard to informed consent, how to understand all those voluminous documents that need to be understood. So, and second is we do not know that there are clinical trials because it is mostly within the community of the physician. I rather it is within only the physician's patients that they are able to disclose that there are clinical trials. So maybe a website where it is laymanized so that we patients can understand and have access to what clinical trials are out there. So, and third, is that aside from orientation, website is also a collaboration with the society. In the Philippines, we have what they call the professional clinical researchers of the Philippines. So we are going to collaborate with them so that at any time that they would be needing patients and all that. So it's like an alliance of researchers and patient alliance. So it's alliance to alliance so that they will be able to get or will be able to disseminate information regarding clinical trials without necessarily going to the patients themselves. So we will be the ones who will cascade that request from different clinical research assistants or groups or companies who need patients to be part of the clinical trial.
Thank you, Fatima. So Papo is going to play a very, very important role in the Philippines. So Nicholas, I mean, we've heard Kenneth and, digitization that's happening in Singapore, as well as the issues that have been faced by Fatima and, in the Philippines. Do you have any thoughts for the region and, with some of the solutions that you bring in your pockets for us?
Thank you, Raj. And just to give a little bit to the audience about where it's coming from. So basically, I'm representing patient-focused medicine developments, and it's a global initiative with 36 members. It's a mix of patient organization, public health authorities, and industry. We have a global aim, but I've been active for the last few years, mainly in the US and in Europe, and we have developed a lot of materials to actually make patient engagement happen. And I will come back to that. So that was just to give a very small piece of context. The first thing I'd like to do, and I hear all the testimonials from the patient organization in Asia, and the first thing I'd like to say is that just to highlight the added value and the critical role patient organizations play in a crisis moment. And I also would like to highlight that they do that in a moment where there is a double stress on patient organization. First, the pandemic and the increased demand from the constituency, the patients. But at the same time, as an organization, it is even more difficult to survive because the usual revenue streams to fund these activities were actually challenged. No face-to-face meeting, no conference, and so on. And so these organizations are extremely dedicated to make their mission happen in an even more difficult context, while actually they have even less means or they have to reinvent certain things. And so it's really important to acknowledge that and to actually be very grateful that you here on the panel, but also all the other organizations on the field have done that. And I've seen that across the globe. It has been a challenge a double challenge for all patient organizations across the globe. So that's the first thing I wanted to acknowledge. Now, and I might link a little bit to the last point from Fatima on clinical trials. We have co-created, so it's a co-creation, really meaning researcher, patients, academic, industry people, health authorities sat together for now 5 years of PFMD, and I've created some material. And so it starts with simply how to work together, whatever is a project, 7 dimensions to respect. That's the very first piece we have developed. But we also went, it's the foundation material, but we went for much more specific how-to modules, like how to design a clinical trial with patients. And actually, we don't write it for patients because in the end, we would like the industry to onboard the patient the right way with the academics. And so actually there is a first training online. We can share the resource after the meeting. It's in English for the moment. We are planning to translate these trainings and these materials in the next few months and years. We have a lot. But the idea is really to have how to define the relationship between patient organization and the other stakeholders, then how to provide very concrete tools on how to make a specific activity happen, like a clinical trial design, for example. The next point I wanted to mention is that we have also addressed, and that might require a little bit more of adaptation to each country specifics, but we also have developed tools like what is a contract which is well balanced between industry and patient organization. And of course, we are defining some principles, but we also will have to adapt to the local specific regulations in place. That's different in each country. Still, there are some key principles that should be applied across the board when they can, at least. And so we have developed tools like that, and I really think that that could be helpful. And I'm coming here with a very open mindset to say, okay, what could work? How can we start a discussion, and how we can bring that to 1 to 6 countries or the whole of Asia? You mentioned, Fatima, the role of the private sector, and I think that's something I've seen across the globe as well. This willingness to partner, because actually what patient organizations have done is something the private sector cannot do. I think this kind of pure representation of the patient community, this very credible voice to represent that patient community, this idea that there is, I've heard ethical guidelines and so on, only patient organization can design that. And so I think what I have seen across the globe is that in this context, I think at least with what I have seen, and if you talk to the right people in the corporate side, I could really see this willingness to help and to support across the globe. So that's something important. And then the last point on digitalization, that's at the same time a threat and an opportunity. There are plenty of situations where it's a plus. It might also become, in some situations, an even bigger discrimination than what we have today, because of lack of access to some tools or to some solutions. So we have to be careful. So I think for me, I have to say, I think overall it's an opportunity, but we have to be very careful on how it doesn't create an even bigger divide for vulnerable groups that we all try to protect. So that's for me like yes, let's go for more digitalization and have more impact through digitalization, but let's make sure that we don't leave anybody behind in the process with the new normal with digital tools after COVID.
Thank you, Nicholas. Yeah, sorry. Thank you. Yeah. Could we now move to Ekawat, who will give us the Thailand perspective of Thailand, as well as share with us a little bit of the work. Ekawat will also go into telling us about home infusion in East Asia and the need for development of guidelines.
Hi, Raj. Thank you. Thank you for having me today. I will start with explain a little bit about hemophilia as a common rare disease. As myself, I have a hemophilia. It's a chronic disease and genetic disease. So I born with this disease. I believe it's nobody understand how I feel when I have breathing this situation, especially in my joint. And it was very, very hurt when I have that situation. When I was young, I don't have anybody to talk about my hemophilia. It's just no patient club. Especially my parents have to deal with the hospital issue by ourselves. Until 10 years ago, I met a young man with a hemophilia, and he said that he hurt so bad his ankle, and he didn't want to have this leg anymore. And I feel that that is was what I thought when I was a kid, because it was hurt so bad. So I didn't want to have this leg anymore. I want to cut it out for my life. So after that, I think like Vedas, we should get together as the patient group and be able to talk about these kinds of things, sharing experiences. And we were so lucky that our patient club is not start from the patients. It starts from the doctor who initiate this group. And then we collecting a group of parents and social worker and just a small group of patients because they barely can walk to join us 10 years ago. And that we start a small group. In 2002, we start to have a patient group, and we start to have a committee to work with the activity and build up the strong community in Bangkok. And I have been working with this committee more than 15 years right now. And I believe that two things that's my role all the time, even in the past until now, that I try to work with a patient club, is building a relationship and building trust. When we talk about relationship, it's so many perspectives though. It's peer-to-peer, patient-to-patient, that we help each other. Family to family, they can sharing experiences. They can talk about how they raise a kid with hemophilia or any other rare diseases. Can do the same thing. I believe we start with this. It's just common basic things. And the relationship with the doctor. I don't know whether in Asian culture or maybe in Thai culture, the doctors speak louder than the patients. If we want to do something, if we collect the patient group, the first group of the stakeholder that can help us to initiate this group is the doctor, because they know the patient, they know the family, they know what the patient needs, and they can recommend that, okay, now we have a patient club or group that they can join. This is the relationship that I try to build up all the time with the doctor in the city hospital or remote area, to build up this community of the doctor working along with the patient organization. And when the patients group and the doctor work well together, and we can talk about changing some policy, or changing something that the patient can get benefit from the government. And the patient and the doctor go together to talk with the government representative. Because when the patient go to see the government representative, it's so difficult to talk in the medical perspective or how to treat the patient. So we need the doctor to go along with us. In the past, hemophilia is more hospital treat. They're not going to believe that the patient can do the self-infusion at home. We build that trust when we have a good relationship with the doctor and the government representative, that the patient can take care of themselves. The parents, they love their kid. They can learn how to do infusion. So that we start to have the program called the Early Treatment Program in Thailand. It's more than 10 years. Basically, the patient can keep we call the factor at home in the certain amount, that enough for them to take care of themselves with the home treatment. But before that, they had to come to the hospital or the center to get trained with the self-infusion, how to keep the factor in the appropriate way. And that in the beginning, it's so difficult because some family, even the refrigerator, they don't have refrigerator because they live in the remote area, they're really poor. And that part, the patient organization can help. We did the fundraising to get the refrigerator for the poor family. And we building trust with the government that we can do it. Trust that we train each other, and even the doctor go to the remote area, they will go with the patients. So I think we proved that the patient organization reduce the doctor work, hospital work, and even especially in the COVID-19 situation, the primary health issue play important role in this situation because the government cannot take care all the area in the country, but it is primary health care can help each other. And we built this 10 years ago. Right now, we have a patient who cannot travel to the hospital because we get the lockdown, but the patient can help each other. They borrow the factor that can help to do the self-infusion together. I think that hemophilia is one of the diseases that showed us you can trust the patient to do the self-health care at home. And the patient organization can help the government to reduce work and save the patient who live far away from the city hospital. And I think in the futures, we plan to have technology to connect with the patients, but it's slow step because in Thailand, I think it's minority of the patient can access to the technology. Before we use the technology, we have to make sure that we educate them, we introduce the technology, that we have a group, number of the patient that can access to this technology, that we connect with them with the Zoom or others application. But instead of bring them come to the Bangkok, big city, we spread out to have a chapter. So now we have 5 chapters across the country, and they can help each other in that area. In the past, they have to come to Bangkok, but right now they can support in their area, and they have their doctor to support them in 5 regions. I think we move on with the technology, and we try to talk to the government to increase the beneficial from government to hemophilia. And we are hemophilia now helping the rare disease, other rare diseases to get the benefit like hemophilia also. And now in Thailand, we start to have 24 rare diseases that get the universal healthcare coverage from the government with the limited budget. But it's a good start. Let's just start this year, and the next year they try to increase the number of diseases and increase the budget. This is the situation.
Thank you, Ekawat. So I hear very strongly here that even in the Philippines, even in Thailand, this trusted partnership is very much part of this region's culture. And I think Ekawat brought it out very clearly. The culture really sets the trend on how we engage patients moving forward. With that, I'm going to come to Indonesia and introduce Penny to give us an idea on the COVID situation and the financial help that patients and their families would have received during the challenging moments. Yeah.
Thank you, Raj. Thank you for having me. So let me introduce myself. I'm Penny, and I am co-founder of Indonesia Rare Disease Foundation. It's a non-profit organization that incorporated in March 2016. For over 4 years, Indonesia Rare Disease Foundation accomplished huge impacts for rare disease patients in Indonesia, including tax exemption, easy access for orphan drugs and orphan food, and we also have an MOU agreement with the Indonesia FDA, Ministry of Finance, Ministry of Health to give special access for emergency orphan food and orphan drugs to import it outside Indonesia. So that's our achievement for over 4 years. So back to the question that Raj was questioned me about what's how the patient in fact affected financial from pandemic and how we support to support provider in this area. So I want to share our current situation of our country, Indonesia. So the first quarter 2020, Indonesia government targeted the economic growth is above 5.3%. But in current situation, we only reached 3% due to 3 months global pandemic. So during ongoing pandemic, also government recognized 3 million job loss. But in actual, the unemployment is near to 15 million, and most of them are the informal work sector with daily basis income. In relation with rare disease patient, based on our 2018 rare disease impact study led by our doctor, Professor Damayanti Rusli Sarif, before pandemic, out of 250 respondents, only 34.9% say that they could afford to pay the treatment of rare disease experienced by the children. The rest feel unable to still hesitant or to be able to cover the treatment of their children. So during this pandemic, many parents lost their jobs, and especially for children with rare disease family, maybe only 10% of families afford the treatment for the children. So as the report said that 90% of the families in this rare disease are in the informal work category with daily basis income. So it becomes very difficult because actually children with rare disease not only need treatment or medicine, they really need balanced nutrition to avoid stunting and malnutrition, which result on the progressivity of the disease. So what we did or what we do as a foundation or patient organization to build the patient engagement, we try to provide beyond the treatment supports or financial support, such as economic access, where we try to take the opportunity during this pandemic. For example, we ask the patient to sell like COVID diagnostic tests, health equipment such as mask, hand sanitizer, disinfectant. So this one is supported by one of Indonesia pharma companies. So where the proceeds can actually enjoy directly to them. So I think it's beyond all of that, we need to focus in the future based on what we experience today, pandemic, that we need to make an event that generate basic necessities beyond treatment itself. So like food, shelters, or easy access that's really needed in the future for after this pandemic. So my opinion, this pandemic forcing us to be more advanced 5 years. So with all digitalized and to think out of the box how the new normal or normal condition to survive. So I think is that's the most important thing for us as a foundation and to get along with the patient engagement. Thank you.
Yeah, thank you, Penny. I think well said. I think what we're trying to identify now is the new norm and the patient engagement in the current setting, as well as I think what we've seen very clearly from Fatima as well as Penny is the loss of income and the question of affordability that's sustainable for areas in rare disease treatment and oncology, as well as the new plan that's needed. Nicholas, any thoughts on that and some of the resources that you might have in mind or can share before we have Elil round up the expert opinion. Yeah.
So on the loss of revenue, that's something that it will be very different. Europe, US, or Asia. That's very different context there. And so what we are doing, which is common across all patient organizations globally, I think, is to better position the patient community and access to treatment, and as Penny said, beyond treatment as well, care as a whole. And so that, I think, is something that all patient organizations are doing. For me, it's not one tool that will solve that. It's more the value case of patient organization and the message they get through to the health authorities, especially, to actually help and reshape the system to take into account patients. You mentioned it, oncology or rare disease, that are really suffering from the current system they belong to. And so for me, it's on that specific question, I would be more like, we need to build the conditions for more patient representation in health systems. And that's not a tool that do that. It will be advocacy. And I think the vision we try to put together is that advocacy, not one-on-one organization with fragmented advocacy, but one network globally of patient organizations that can support patient organization at the national level to actually change the national system. And by showing how we can build a value case for patient engagement and patient organizations.
Thank you, Nicholas. Now over to Elil, who will be the last in this expert on patient panel, and then we'll probably take a couple more questions as a collective panel before we hand over back to John. Yeah.
All right. Thanks, Raj. So we are talking about patient experience and patient engagement, and well, the question is, how far along are we in Singapore as far as this is concerned? So just before we go into that, in North America and Europe, many healthcare organizations have successfully incorporated patient engagement and patient experience into their organizational culture and are way ahead of the rest of us in this region, right? So organizations like the Barrel Institute actually collate all the best practices and provide resources and guiding principles for the global healthcare community, and they find that in order for us to succeed, there must be leadership which is committed to expand capacity and resources to identify, select, and engage the best talent at all levels of the organization, and to have a process in place to advance the development to champion the cause, right? So then we must clearly define the kind of patient experience we want to provide, and then ensure that there's a clear and shared understanding of the vision and a positive work culture throughout the organization. So we also must find ways to encourage and invite patients and families to become more engaged partners in their healthcare experience, understand and measure their inputs, then engage the voices of the staff, the clinicians, and the healthcare professionals to help shape strategy, solutions to current issues and opportunities. And we must also remember to address conscious and unconscious biases and break down barriers to accessing care. We need to look beyond clinical needs and also consider social, emotional, and financial issues. I think both Penny and Fatima had mentioned that. And on broader population health issues in our community. And finally, we need to partner with organizations beyond the walls of the healthcare institution and across the organization to support quality care and effective transitions across the continuum of care. So where do we stand in Singapore on a scale of 1 to 10 in this patient engagement and patient experience equation, right? I think right now we are about 4 upon 10. We have already started, and I think we've made inroads. And we started sometime in 2017 with the inception of SPAN. SPAN is the SingHealth Patient Advocacy Network. It was set up by the Institute of Patient Safety and Quality. So SPAN members are from a pool of committed patients and caregivers They are involved in focus groups, work group committees, and have even represented SPAN as keynote speakers. And the important thing to remember is SPAN is co-chaired by patients. So it is not chaired by the head honchos from the healthcare institutions, although they act as in an advisory capacity. So the network of patients and caregivers act as advocates, lending their voices to issues that matter to them. And SPAN patient advocates are involved in aiding the design of services for cluster-wide transformation projects and new infrastructure development. So I think we are making strides in the right direction and are constantly learning and evolving as an advocacy group, sharing patient experience with the healthcare professionals. And I want to add that during this COVID-19 situation, we have not stopped carrying out our activities. We are reaching out to and engaging our members through e-meetings and Zoom sessions. As Kenneth had pointed out, the level of digitization here in Singapore is fairly high. And to harness the patient experience and stories, and then sharing these with the healthcare professionals at various touch points through video recordings and participating in improvement projects via Zoom and other similar platforms. And at the patient organization level, during the COVID-19 pandemic crisis, the Ostomy Association, which I head, needed to provide assurances to our patients with regards to access to stoma supplies from the vendors, and also access to psychosocial support. So we work with the appliance vendors and the support groups in the hospital and organizations like the Singapore Cancer Society, and reach out to patients through the different modes of communication to tell them how they can go about accessing these services during the partial lockdown situation. And as for our support group members, we have moved to holding our support group gatherings via Zoom, and for one-to-one support over the phone and WhatsApp video, as well as Facebook Live and Facebook Rooms, right? And we do also have enrichment classes that members used to participate in pre-pandemic, and now we have moved on to holding all this in the Zoom platform. So as far as possible, we try to keep all our support group members engaged and all the members under our patient organization to provide some kind of reassurance, because not only are they in a situation which is not, how should I say, it's not normal because they have to deal with their condition. Most of them are also, most of them have the condition because of cancer as well. So they all belong to a vulnerable group. And in addition to the anxieties that come with their condition, and to add on all the restrictions that were imposed during this partial lockdown, can be quite a demanding task to deal with all that. And that is where I think the support is so important during these hard times. Back to you, Raj.
Thank you very much, Fatima, Kenneth, Elil, Ekawat, Penny, Nicholas as well for your input. We will now hand this back to John and take it to the next segment of the evening.
What we'd like to do in the next section is to firstly ask Kristen from Faster Cures, having heard this, the commentaries from our patient leaders in the region, from your perspective from North America, what have you sort of taken away from the discussion so far? And do you have any thoughts, both in terms of solutioning in the current context of COVID-19, but also in a kind of post-COVID situation going forward? So Kristen, over to you.
Yeah, thank you very much, John, and thank you all so much for involving us in this session. Thank you to all the attendees, obviously, as well. Let me just begin by saying a couple of words about Faster Cures and why we are part of this conversation and our interest here. We have for many years supported the more regular and rigorous practice, I would say, of patient engagement, specifically in the biomedical research and development process. That's our focus at Faster Cures, so is our focus with regards to patient engagement as well. And we have a broad community of patient organizations, mostly within the US, who are engaged in research and with whom we have worked over many years. I will say that much of what I have heard resonates very much with me, and we are seeing similar things in the US context. I appreciated Ekawat's comments about the role that patient organizations play as a hub of relationships and trust with patients. That's a critical role, obviously, that patient organizations play. I have to say, I have taken away some lessons that I would like to think about how they apply in the U.S. context. I was very impressed by Fatima's, for instance, comment about how her organization was involved in the development of guidelines for patient care in the context of COVID. I'm not aware that that has happened in the U.S. And at least to any concerted degree. So that was a very interesting takeaway for me. Also, I mean, I'll just say that we are, patient organizations in the U.S. are experiencing many of the same things. Certainly the loss of income, the impact on fundraising, layoffs of their own staffs. Research that they are supporting has been stalled. There has been an impact on the patients, the care of the patients that are their constituents. I think we are all committed to ensuring that there is research going forward into how all of this will play out. What will the impacts on healthcare be in the long term for those patients by hospital visits delayed or participation in clinical trials stalled. So they are all feeling those things acutely. I think they are also experiencing many of the things that Penny and Kenneth and others cited, which is the stimulation of a lot of creativity about how to continue to engage with their patient communities and serve their needs and serve some needs that maybe they weren't having to serve before. For instance, their financial needs. I think in the US that was something that patient organizations were engaged in, but maybe not to the same degree they are now with so many people having seen reductions in their incomes. I did want to make one point that I have been thinking about recently, and then it really came out in this discussion for me, which is that there is a difference. We have seen many positive developments for patients in the context of COVID. The increased use of telehealth visits, digital tools, remote participation in existing clinical trials to some degree, mental health, more focus on mental health and delivery of mental health services remotely. And I think we want to see those things preserved in the US context. Those things are tied to the public health emergency. So we are thinking about, okay, how do we make sure they continue after the public health emergency is over? But there is a difference to some degree between patient engagement and patient centricity. So I think there have been some patient-centric developments, but they haven't necessarily involved much meaningful engagement with patients in the US, at least, necessarily. And so I've been thinking about how do we engage patients in the context of a public health emergency? It's different than the context that we've been operating in the patient engagement realm until now. And I think that Raj has started to lay out the elements of a framework ame for that in your presentation, Raj, thinking about what we need to do going forward to put more of a framework and some guidelines in place around how do we do this in a context where everyone is moving very fast with the best of intentions. But I think one casualty has almost certainly been, at least in the US, making sure patients are part of the decision-making process about decision and care at every step, which I think is the goal of patient engagement. So that's just one observation that I'll contribute to the conversation. And thank you all so much for the on-the-ground view of what you're experiencing. It was very informative.
Thanks so much, Kristen. Nicholas, could you sort of sum up your thoughts from the earlier discussion? You have highlighted certain things like the need for capacity, and you expressed the concern about a digital divide potentially coming up, even as many patient groups have begun to use virtual means to connect. So Nicholas, your thoughts on the discussion and solutions going forward, please.
Thank you, John. So yes, sure. So I really like how Christine laid out the difference between patient centricity and patient engagement. And indeed, in the context of a crisis, we have done a lot for patients, but not necessarily with patients. And actually what COVID-19 is demonstrating is actually the the failure of health system in general. And I'm talking from surveillance to anticipation to then dealing with the crisis when the crisis is there. And I think in many occasions, patients were not at the table. And sometimes you can understand why. Sometimes it's just a reflect of the current status of how valued is the patient contribution by other stakeholders. And so I think, to come back to the framework, I think it's really important to, in this framework, define the value of the patient community. And which patient community? When are we talking to patient experts? When are we talking to patient organization? When do we talk to patients, lay patients with an experience of the disease? I think all of that has to be structured quite well to actually come to a value proposition to our systems. But me personally, I'm deeply convinced that in a very fragmented health system where we could not even get the right numbers in terms of the pandemic, for me, the patient community as a whole is potentially the red thread and the connector of all these different silos that we have built for decades in our health systems. The patient community is actually the only stakeholder on the table that can connect all the dots and make sure that it makes sense and offer a coherent experience to the patients to the best of what the system can do. And so for me, that's the idea of a framework is really, in the context of a pandemic, is really interesting to me. You mentioned the digital divide. So for me, that's really an attention point in the sense that we can, in the context of telemedicine, for example, I think we are at a stage where we can go to telemedicine for two reasons. One, because it really helped the patient community in this context, and it could help the patient community in many contexts. I know that in the US, I know some patient advocates that will say, we have been asking that for 2 decades, and now suddenly in overnight, it's actually becoming a reality. And so it's a plus for the patient community. Now, the scenario I would like to avoid is that we as a system really push for it, but not for the good reason, just because it can be financially more interesting. And that I see we are on the edge of doing it, but I'm not sure we do it for the right reason. And if we don't do it for the right reason, what we will end up doing is to actually separate even more, isolate even more the patient, the vulnerable groups, the patients in the rare disease community. I can also mention pregnant women or patients with mental health issues that could really be even more of a divide than what the system that we have today. So I think it's really important to make sure that we make these shifts towards the new normal for the good reasons and for the good reasons only. And that is where I think we, as our common community we have around the table today, we make sure we push for that and don't let the system deviate from the real value that we can bring with telemedicines. And that's just one example, but I think it's a good example to illustrate all the potential benefits, but also the risk that goes with it when we talk about digitalization. Thank you, John.
Thank you, Nicholas. And Raj, would you like to sum up your thoughts to help round off our discussion today?
Yes, thank you, John. I think lots of good comments and propositions from the whole team, from the region, as well as from Christine and Nicholas as well. So I think some of the startup points would be, we need something to be evidence-based. I think we need to collect the data as to what we need to do next. Patient insights, the capability that they have. The next, I mean, leave off Christine's point. I think what we need to do is to have engagement with centricity so that our programs are a bit more focused, rather than to actually just think about having a patient centricity plan when the engagement is actually kind of weak, or having an engagement plan when there is no centricity. And I think the next point would be then to try and figure out how do we decentralize patient support programs and empower the patient groups to actually play a key role. And I think that was Nicholas' point as well earlier, and many of the points are raised by the experts. I think the last 2 points that I'd like to bring for this whole region, because this whole region is, as mentioned by John, nascent in development, I think it's imperative to know that we need to actually start from ground zero. That's one. We need to put in foundations that will keep it going for the future. So I think with COVID near and maybe here for the long haul, I think we need to actually develop plans for patient preparedness. So I think, how do they cope with the disease? What do we do next? What is the new norm? I think it could take forms of disease-specific issues as well, something for oncology, something for rare disease, because I think one size may not fit all, and also then to empower patient groups and patients to be ready digitally, because I think the plans by Nicholas and the resources have been great. But this region will need to have some level of uniformity, and so we probably will need to start somewhere. And I think if we start off with a survey in the region, I think that will be useful, and I think it's come in handy for our next roundtable meeting in October. Yeah, so those are my quick thoughts, John.
Well, thank you very much, Raj, Kristen, and Nicholas. Thank you also to Kenneth, Elil, Ekawat, Fatima, and Penny. It's been a very significant and enriching session today. And I think we've taken a lot away. I mean, as I said at the beginning, I think with so much going on in COVID-19, we've sort of taken our eye off the role of patients and patient centricity to some degree. And I'm glad that in today's session, we're able to refocus that aspect. I think you'll agree that based on all we've heard today, patient engagement continues to be an issue of huge importance and concern during this time of COVID-19, but also as we look forwards to the kind of post-COVID new normal that Raj mentioned. And in fact, what we're being forced to look at in terms of either new paradigms, whether it's greater dependence on digital options, but also remembering the difficulties that patients and their families are facing, as we were hearing about job losses and revenue loss during this time. These are pressing issues that need to be addressed so that we're able to really continue the good work that has been started in the region over the years. To this end, CORE will continue to work together with our patient engagement partners in supporting capacity building and also constructive engagement with health policy makers, healthcare professionals, researchers, and industry. And as a neutral academic center, we see ourselves as an enabler to promote evidence-based and collaborative engagement in this region through facilitation, coordination, and collaboration, and certainly working with our partners in Europe and the US, together with Nicholas and Kristen and their respective organizations. And what I'd like to share is that we're now working on a multi-stakeholder initiative that we are calling CAPE, C-A-P-E, which is an acronym for the Collaboration to Accelerate Patient Engagement in the Asia Pacific. And so with our experts, we will, as Raj was talking about a survey, we will in fact be working with him and the patient groups represented as well as others, conducting a survey of patient group leaders in Southeast Asia over the next few weeks to better understand the current landscape and to dive deeper into some of the issues we've heard about today and also begin to figure out what we do next. The survey results will help to define more focused follow-up that is also culturally appropriate for our Asian context. And Raj has emphasized this point many times in this webinar, to really be able to have something that's culturally contextualized, even as we want to grow where patient engagement and patient centricity is in its nascent form now. Because the nature of engagement is not always as open or forthright compared to country settings like in the US or Europe. And the results will also clarify key themes for our next roundtable, which is actually planned for October this year, but which will now be a virtual by invitation event, which will discuss gaps and solutions that we then plan to share with a wider audience. So as we come to the end of this webinar, thank you again for your time. I hope you found this webinar useful in clarifying issues and also highlighting key ways in which we can continue to advance patient engagement in these extraordinary times that we live in. So on that note, thank you very much for being with us. Thank you again to our experts and panelists. And with that, goodbye, and please stay safe and well. Thank you so much.